So what I'd like to do is take you through a story, and it's called the Type 2 Diabetes Story. And I'm going to use a number of video clips and audio clips that hopefully you'll have fun with, and we'll see how it goes. So it starts off like this. So the real title of my talk is an evidence-based discussion about type 2 diabetes I would like to have with Tom Hanks. And you're probably wondering, why the heck would I want to have a conversation about type 2 diabetes with Tom Hanks? And the reason is because on October the 7th, 2013, there was a big announcement made by him, and I'll show that to you in a minute, and it was picked up by all the news media, and they said, Hanks dropped the bombshell. Hanks' showstopper at the opening gala has been overshadowed by a diabetes scare. Hanks' diabetes announcement shocks fans. And Tom Hanks reveals major health scare. And this is what he said.
I went to the doctor, and he said, you know those high blood sugar numbers you've been dealing with since you were 36? Well, you've graduated. You've got type 2 diabetes, young man.
And so, I mean, for those of you who don't know Tom Hanks, he's made some incredibly great movies. Toy Story being one, Forrest Gump, Philadelphia. And in fact, he's actually widely known as one of the nicest guys in Hollywood. And he's just like it seems like he's just a basically normal kind of guy. And what I thought would be very interesting would be, I know a fair amount about evidence around type 2 diabetes. And what I thought would be interesting would be to have a conversation with him about that. And so when you see that picture in the lower corner, there'll be a clip that will be coming up, and it may be something he might have said, I don't know, about something I'm saying about type 2 diabetes. So if you listen to the media about type 2 diabetes, you will see pictures like this and hear this.
Diabetes is a ticking time bomb. It's a silent killer.
And I would imagine if I was anybody like Tom Hanks and I heard that, I would probably say something like this.
Houston, we have a problem.
Or maybe this.
This is the perfect time to panic.
Because that sounds terrible. You know, the silent killer, and it's a ticking time bomb and so on. And what I want to do is try and put it into perspective. So I'm going to help you do that by looking at a variety of the diabetes guidelines. And we've had 3 that have come out literally just in the last few months. And I'll talk a little bit about those. One of the concerns about all of these types of guidelines is that most of the recommendations in the guidelines are not based really on well-designed clinical studies. And it's not just these guidelines, it's guidelines in particular. You often can't use them to make individual estimates of benefits and harms, so you can present them to patients to help them make decisions. And often, and I've done some work with a colleague of mine where we've looked at the values and preferences. Are they implicit in the guidelines that we should be talking about patients' values and preferences? Because all of these conditions are very value and preference based. And in fact, one of the most recent guidelines that came out from the American Association of Clinical Endocrinologists, we felt they were so poor that we had to write a letter and an article about that. And so I helped these guys draft this, and we just published this recently. And there was a lot of concerns that we had with this guideline in regard to the transparency of the people who were doing the guideline, how they dealt with conflicts of interest. But much more importantly was how they set up the guidelines, and there was nothing to do with patient values, and it was really impossible to find out that there was any foundation of how they even thought about evidence or used it, or even the strength of the recommendations they were making. They were just exceedingly weak guidelines coming from a very august body, and it was of concern, and so we published an article, as I said, about that. As I was saying, many evidence-based guidelines are not based on solid evidence. If you look at cardiovascular guidelines or infectious disease guidelines, and you look at the level of evidence that supports the recommendations, only about 10 to 15% of the recommendations in there are based on well-designed randomized controlled trials. And I can tell you, when you go back and look at the evidence that they're using, it's for about half of those, the randomized controlled trials that they're talking about actually don't relate to the recommendation. It's quite fascinating. So we're probably talking around 5 to 10% of any recommendations in guidelines are based on really solid evidence. Most of them are based on opinion. Now, it's expert opinion, so that's certainly of value, but we're still talking about half of them being based on sort of opinion. And what's really also interesting is Peter Lowen and I looked at all of the clinical practice guidelines in Canada about 5 or 6 years ago, and we looked at the blood pressure, cholesterol, glucose, and bone density, and we found that of the 197 pages, and it was 90,000 words, for conditions for which it's all about patient preferences and values, there was only 0.1% of those words had anything to do with patients' values and preferences. So it's almost devoid in guidelines. It's getting a little bit better, but it's not perfect. And you were unable to use the guidelines to help people make decisions because the information wasn't presented in a way that could help you talk about the benefits and harms. So there's some new guidelines that have come out recently, and I've done the same sort of thing where I've looked at those guidelines to see what are they recommending things. And on the top of this thing, you can see going sort of from your, what would be that? That would be your left to right. A being very higher evidence, and B and D sort of being sort of consensus. And when you look at things to talk about targets for type 2 diabetes, glucose monitoring, which is something that some people recommend, and also the pharmacological treatment or the treatment in general, when you look at the evidences, you can see that about, in this case, 7 of the recommendations are based on randomized controlled trials or cohort, but you can see a large number are still based on opinion. And the same thing is in the States, although it's funny when you see two groups look at the same evidence, yet they come up with completely different numbers of studies that they can use to justify their recommendations. And so when you add all that together, we're still talking only about 20% of the recommendations are based on randomized controlled trials. So it's just a sort of a framework to sort of appreciate how that's going on. And what's really interesting, there are dozens and dozens and dozens and dozens of trials that have looked at the treatment of type 2 diabetes and looked at outcome measures. And interestingly, when you actually go back into those guidelines and look at what studies they look at, they basically avoid almost all the trials that don't show benefit. And it's kind of a weird thing because if you look at all the evidence, and I'll show you that as it goes along, it makes it very difficult to make the recommendations if you look at all the evidence. So, as you know, Tom Hanks has put out lots of really good movies. He's got some of the highest ratings on Rotten Tomatoes. He has 15 films that got an 80% or higher rating. That's really impressive. And as you know, he's got some really good films. He puts out some stinkers sometimes. And this one was one of them. And at least the way I've looked at these guidelines, and I've looked at them in detail, if I was to, at least from an evidence-based informed decision-making perspective, I would give these not a very high mark. I wasn't going to give a number because it's so hard to come up with a number of them. But when you look at them, at least from an evidence-based informed decision-making process, there's so many problems from patient preferences, how well they looked at the evidence and so on, that when I look at them, I don't get a good, comfortable feeling that I can trust what's being put into many of these recommendations. So if I was talking to Tom Hanks, I would have said something like that, and he might have said this.
It's nothing I need to know.
Well, yeah, it is. Because you've been diagnosed with type 2 diabetes, you should know the evidence or at least have some sort of appreciation for the concept of how that all works. Because you may or may not know this, but Tom Hanks once tried to fight the Fonz. And even though he may have had the best of intentions, it doesn't always work well when that happens. And we have a wonderful example here of we've now, and even today, a new study just came out. It was 17 yesterday. It's now 18 studies. We have 18 large randomized controlled trials that have looked at lowering lipids with medications or blood pressure, aggressive or not aggressive control. And we've now numerous trials of type 2 diabetes and just general drugs that lower risk factors that have shown no benefit and potentially, and some have shown harm in for patients. So this is 18 studies in a row, large randomized controlled trials in the last 4 to 5 years. There has not been one that's shown any benefit. So it's not even a trend. It's consistent from what I can see. This is really important to know. And he might say this.
What? What are you talking about?
Well, let me try and put it into perspective for you. Here's some really interesting stuff about treatment targets, and it's one of my pet peeves. And how many of you have heard that there are certain cholesterol levels that you're supposed to get to? Have you heard that? Yeah. So it's been ingrained into our whole sort of thought process about cholesterol. And if you look at the 2009 Canadian Cardiovascular Guidelines, they recommend targets of less than 2 millimoles per liter. And actually, when you look at the guidelines and you look at what evidence did they use to support that, they'll say it's class 1 level A evidence. And level A evidence means that the recommendation for those targets is based on evidence from multiple randomized trials or meta-analyses. So that's encouraging when you get that sort of an endorsement, and it's based on really well-designed clinical trials. The problem is they didn't really look at the evidence, because the most recent guidelines came out in the States just recently. And it was 2013 guidelines. And for the first time in my career, I actually saw a group looking critically at the evidence and making, I think, what I consider a proper assessment of it. There's other problems with them, but they actually finally started to look at the evidence that's behind them. And this is what they said. Remember, the Canadians said, we have multiple randomized trials and meta-analyses that support this level. They said this. So how can you have two independent people come up with completely different opinions? One's got, oh yeah, we've got dozens of randomized controls and meta-analyses that show that this is it. And they said we found none. And it's because that, to tell you the truth, when you look at the evidence in any sort of critical fashion, it has never been studied. There is not one study that's ever looked at, is there a benefit of getting to different cholesterol levels? And I think they're now, these guidelines have come out, they created quite a stir, but they're saying those thresholds that we used to use, they're almost saying we were just kidding. We just don't have any evidence, and in fact they're saying, you know, it's probably not worth doing it anymore, which is fascinating to me.
Just the facts, ma'am.
So what I want to do is try and give you the facts associated with it and presenting it as if I was talking to Tom Hanks. So I'm going to talk about type 2 diabetes. It is not about getting glucose under control. It's not about getting blood pressure control. It's, can we have an impact on macrovascular outcomes? Can we have an effect on heart attacks and strokes? And can we also have an effect on microvascular outcomes? And unfortunately, for many of these microvascular outcomes, we don't look for blindness and dialysis. Unfortunately, we're stuck with looking at things like proteinuria, retinal photocoagulation, and things like that, which are not unimportant, but they're not nearly as important as some of the important outcomes. But these are the things that we want to reduce. It doesn't matter about blood pressure, glucose, and cholesterol. We want to lower the chance of these. It is outstandingly clear, and I'm not about to stand here and tell you that glucose is associated with bad outcomes. When you look at a graph of the risk of bad outcomes, and as sugar goes up, there's no doubt that on average, as these things go up, you have more heart attacks and strokes and so on and so forth. And it's very clear, there's a meta-analysis of all of these sort of cohort trials that have looked at it, and for every 1% increase in A1C, the risk of cardiovascular disease goes up by 15%. So that's not in debate. What's in debate is, can we benefit people by lowering it? Now, it may assume that would make total sense, but that's not always, just because it's logical doesn't mean it's necessarily going to work. So the question is if we lower glucose or get rid of some of these risk factors, does anything change? And we've got a lot of information about that, and I'll show you some of that as we go along. One of the first things you have to realize is, how do we diagnose type 2 diabetes? Well, there's 4 different criteria that we use. And you have to be above a certain fasting plasma glucose, you have to be above a certain A1C. And what's really interesting is that these are all arbitrary breakpoints, at least relatively arbitrary breakpoints. They're not set in stone. They're not one of the 10 commandments. They're not any of those sorts of things. They're relatively arbitrary. And when you actually try to find evidence to support them, you very quickly realize that they're hugely based on opinion.
Hey, wait a minute. Settle down here. Let's think about this.
So we're going to think about this. So what does it really mean about this whole concept of these thresholds that are giving a person a diagnosis of what many people think is a serious, very bad condition? Well, if you go back and look in the literature, where did they get these thresholds? Well, the threshold for the A1C is an inflection point for retinopathy prevalence. And you can see it on the graph. Retinopathy goes up as you get past that A1C is 6.5. And that is actually what has been used on a regular basis for defining that threshold. Now, is that appropriate or inappropriate? I'm not here to tell you which one, whether it's appropriate or inappropriate, but ultimately what it should be is up to the patient to help us decide that. So retinopathy is an issue, but it's one of the very minor endpoints that we talk about in type 2 diabetes.
Mom always had a way of explaining things so I could understand them.
So what I'm going to do is try and be like his mother and explain in a way that he could understand, and even you guys can understand about this process. So what does it mean to have type 2 diabetes? We have a number of tools that we can use to make reasonable risk assessments. So that's Tom Hanks. I don't have all of his numbers because I've never met the man. I'd love to, but I've never met the man. And I've put in as much information that I've been able to find about him, about his BMI, his age. He's not actually had diabetes for 5 years, although it doesn't really matter in this process. He's a non-smoker from what I know. And I gave him sort of averagey, maybe a little bit high blood pressures and cholesterols, but nothing major. And what I want to do is show you, if you put this information into a calculator that makes an estimate of risk, what happens to his risk as A1C goes up. So this is his chance of 10-year chance of developing cardiovascular disease. That is what happens when glucose goes up. So as A1C goes up, there's no doubt glucose cardiovascular events go up. But it may not be quite as much as you would have thought. Now, I don't know if you know this, he actually played a woman in a TV show called Bosom Buddies. So if he was really a woman, his risk would have been this. So women have lower cardiovascular risk, but those are the sorts of numbers that we can figure out and make a reasonable assessment and tell patients this is what it means to have an A1C of 7, 8, or 9. So let's put this into context about the diagnosis of it. This is considered normal. So if your A1C is less than 6, you are considered normal. A word that I detest. Normal is just, why would we even say normal? Because that just implies everybody else is abnormal. When in fact I think we're all normal and quite abnormal on a regular basis. So that's, if you were to go and get your A1C measured, if it fell in there, everyone would be happy you'd be normal. So if you are this poor person who goes in and has a measurement of their A1C and it falls between 6 and 6.5, you'll be told that you have pre-diabetes. What that means is, instead of your 10-year cardiovascular risk being 18 or 19%, it's now maybe 20%. So pre-diabetes means you have a 1% increased risk of cardiovascular disease over 10 years. Is that big or small? Guess who should decide? Tom Hanks, or the patient that's in front of us. Diabetes is not a black and white thing. There's a whole spectrum. But if you're above an A1C of 6.5, that is considered diabetes. So let's put this into context. 90% of diabetics fall between an A1C of 6 or 9. 55% of diabetics fall between 6 and 7. So they have, and I'm going to use this term totally inappropriately, what people would call mild diabetes, or sort of pre-diabetes things. But you can see there's very little difference in 10-year cardiovascular risk between some of these levels. So the mean A1C of a type 2 diabetic is about 7.2. Our treatment targets, we try to get people below 7. Again, remember, it's an arbitrary threshold. It's all about just reducing risk. And in fact, almost no type 2 diabetics have noticeable symptoms. Some people suggest you might get some symptoms of being thirstier or drinking more at an A1C of 9, but it probably doesn't occur till even way over there. So the vast majority of people who have type 2 diabetes have an asymptomatic condition. What it means is their risk is increased based on glucose. So that's what having a diagnosis of type 2 diabetes means. And if I was to have a conversation with Tom, I'd be saying, this is what your risk would be. Because now we've got to talk about, can we actually reduce that risk? So people will say, well, but aren't there other complications of type 2 diabetes? Absolutely. The best evidence I could find, and this is for lifetime risk. Remember I talked about 10-year cardiovascular, that was 10-year. And remember I said, roughly speaking, 10-year risk would be in a person like that, somewhere between 20, 23, 24%, depending on their A1C. But obviously there are other complications. The risk of clinical peripheral neuropathies, which nobody wants. Those occur in about 6% of patients. But one of the biggest concerns is dialysis and blindness. And the best evidence that I could find is of what is the chance over a lifetime, based on your A1C, of going on to dialysis or being blind, which are very, very important endpoints. That's the lifetime risk of dialysis. At the worst case scenario of an A1C of 11, your risk is 2%. And for blindness, it's about 4%. With the worst A1C you could possibly have, realizing that the vast majority of A1C patients do not have A1Cs like that. In fact, that's where 55% of diabetics sit. Well down on that curve. So their chance of a lifetime risk of blindness or dialysis is for most patients under 1%. So it's actually hard to get rid of that because it's relatively low, at least contextually. When I use low, some people think that's high. So it depends on what you think about it. So he might have said this.
That's it? Doesn't seem so bad.
Now, he may not have said that. He might have looked at that and went, that's a terrible risk. But I know in my experience when I talk to patients who have type 2 diabetes and I show them these numbers, they go, huh, I thought it was more. So the issue now comes into, what can we do for type 2 diabetes? Well, we have numerous glucose-lowering medications. And unfortunately, these drugs are approved not for their ability to lower cardiovascular disease, but whether or not they can lower glucose. Because if you follow the glucose hypothesis, if it's high, it's bad, and then if you reduce it, you should be better. Most drugs, on average, will lower A1C by about 0.5 to 0.7%. And that's over a period of a few months. But unfortunately, there's very, very few head-to-head comparisons. So what does that look like on the graph that I just showed you? This is the same graph that I was talking about. So medications lower A1C by 0.7%. So what that means is, if you were a type 2 diabetic, which you would be called a type 2 diabetic if your A1C was 8, if you took a medication, on average, you see a reduction in your A1C down to about that point. What's the maximum benefit over 10 years a person could ever get from a cardiovascular benefit if we did that? This is the interactive part. Their risk would go from 24 down to 22. Roughly speaking, that's what we'd be making an estimate of their risk if we gave them the medication. So,
not much of an improvement.
Again, that's his comment. Some people may think that's an important improvement, and it may well be, but that's what he said. Here's what's really interesting. We have variability in glucose measurements, and this is one thing that I find really interesting. So if you get told that you're a type 2 diabetic and you measure an A1C, just because you get a specific number doesn't mean that is your number. There's a fair amount of variability. So when you get an A1C of 7, all it means is it's likely somewhere between 6.5 and 7.5. And there's a variety of reasons for why that means. So it's not all that sort of there's a lot of variability in the test. And the same thing with glucose tests. And what's really interesting is you get a fair amount of variation in seasonal variation in A1C as well.
I don't get it.
And I didn't think you'd get it, so now I'm going to show you what that really means. So, remember I said, on average, drugs can reduce A1C by about 0.7. I have a test that measures A1C that when I measure it, if it measures it at 7.5, I can't be confident that it's 7.5 or 7.4. I can only be confident this is probably somewhere between 7 and 8. So if you have a drug that only lowers A1C by 0.7%, it's actually hard to pick up that change because the test is not good enough to pick up that change. And it's one of the concerns that the VA down in the States has had with this, and they're trying to encourage people to not get all bent out of shape about changes in A1C. So my process of how do I believe something works, and I'm not saying this is what everybody should believe in, but it's the way I believe in it. If you're a skydiver and you don't go out with a parachute, how do you test to see if a parachute works? Well, you give it to them, and if they don't die, that's a really good test. You do not need randomized controlled trials for parachutes. Because we get criticized sometimes as being evidence-based people because they'll say, well, you don't need an RCT for parachutes, and you're right. Because everybody dies, and if you use a parachute, not everybody dies. That's actually one of the highest levels of evidence. But when it comes to diabetes or any of these conditions, I think you do need randomized controlled trials. You need to randomize people to drug or no drug, and then look at what happens to all of these things. And then, if you have a whole bunch of these studies, you put them together and we call it a meta-analysis. So we have tons of this information. So let's stand back and go, what could we tell Tom about his risk? Well, we know, even if he didn't have diabetes, if you take A1C out of the picture, his chance of developing a cardiovascular disease over the next 10 years is about 20%. And this is probably an overestimate because most of the tools that we use overestimate things. Because he's a diabetic, it probably adds 4%. And we could maybe, in theory, get rid of 2 of those. So what does that really mean? So if we treat 100 people with type 2 diabetes for 10 years, 76% of them would never have an event anyway. 20 will have an event whether or not they had diabetes. 4 will have an event caused by elevated glucose. And we potentially can, if we go with this hypothesis that if you lower it, you can get that benefit, 2 would benefit. So that means, and this is not this is maybe even an overestimate of the benefit, it means 98% of type 2 diabetics who we treat for 10 years get no cardiovascular benefit. So that's why it's really important that the drugs either don't have side effects or don't have cost. So we have lots of clinical trials that have looked at what happens when we do intensive glucose control. And there's been 3 that have come out recently. Advance, Accord, and VADT. So what do they show? Well, what they do is they take patients whose A1C starts at 8, so they're definitely type 2 diabetics based on our definition. And what they do is they randomize people to glucose control or more aggressive glucose control. And so in the Advance and Accord, they randomize people to get to an A1C of around 7.5, and intensive was around 6.5. And the VADT started at higher numbers. They started at about 9.5 and then randomized people to get either regular control, which was sort of 8.4 down, and the intensive was 6.9. That's really cool. That's the exact type of studies we would like to see, because it's showing, do we get a better outcome if we do more intensive therapy? So what did they show? No effect on macrovascular outcomes at all. All of them were consistent in showing basically no benefit, and in fact, one of them showed increased mortality. The absolute increase was 1%, and other trials have not shown that, but it's just of concern because I think reducing mortality should be maybe one of the things we should be looking for. And obviously, there were harms associated with it, with hypoglycemia. So with intensive glucose control, we have no studies that show macrovascular outcomes, which is really why we're treating it in the first place. There's a benefit. We've seen one trial that showed a 1% increase in death. One of the trials, when they did sort of an evaluation of some of the microvascular outcomes, they did find a 1.5 to 2.5% absolute reduction in things that I think are important. 3-line worsened visual acuity on an eye chart, so that's important, but the benefit is about 2%, which again means 98% get no benefit. But no difference in blindness. They probably didn't follow them long enough, and they may not have been able to show a difference. They showed about a 1.5 to 2.5% reduction in the number of people who started to pee more protein in their urine, but no difference in dialysis. And I don't know about any of you who are clinicians. I've never had a person come up to me and say, my goodness, I'm peeing a lot of protein into my urine. They don't go, that's a really important endpoint. And again, about 1.5 to 2.5% reduction in the number of people who had a loss of light sensation to touch. So there was some benefit, but no macrovascular benefit. So when you look at all of the evidence that we have available, the key drug that we use for type 2 diabetes is metformin. We do that because we have one randomized controlled trial called the UKPDS, where they looked at 700 people and followed them for 7 years, and they were able to show a 7% absolute reduction in heart attacks and strokes and cardiovascular outcomes. So that's why we use metformin as one of the drugs of choice. What's really interesting is a group recently looked at all the clinical trials of metformin, put them together as a meta-analysis. There's 13 trials, and they were unable to show a benefit. So that's really interesting. So the primary driver is this UKPDS trial. And there are no studies that have shown any changes in microvascular outcome. We have sulfonylureas, which have been universally not effective in reducing macrovascular outcomes, with the exception of a follow-up trial, which at least showed at least some potential benefit, and certainly not harm like some of the other drugs that we have. And in this case, the benefit that's being seen is a 3% reduction in retinal photocoagulation. But all the other outcomes have been of no benefit. And these are trials that have gone on, as you can see, for 10 years. And when you do a meta-analysis of the trials, they've not been able to show any benefit in those outcomes. Insulin is even interesting. You can absolutely control people's glucose with insulin. It's really quite easy, just give lots. But actually, there's been a couple of randomized controlled trials. One was a combination trial, and they've been unable to show that giving insulin to patients reduces cardiovascular outcomes. And these are well-designed trials that go on for sometimes 6 years, sometimes 10 years, and there's been no evidence that's looked at sort of the microvascular outcomes. We got the DPP-4 drugs. These are new medications that come on the market. And by the way, these all lower glucose. Just in the last 6 months, we've got 2 clinical trials that have looked at taking patients and giving these drugs for 1.5 to 2 years and showing no cardiovascular benefit. Now, it may not have been long enough, but these were published in the New England Journal of Medicine showing no benefit. So again, we don't have evidence of benefit for these medications. The glitazones, probably if anything, they likely worsen outcomes. Certainly rosiglitazone does, as far as increasing heart failure. And when you look at a meta-analysis of all those trials, there's an increased risk of heart failure, probably, I'm trying to think of the exact number, probably 1 to 2, maybe 4% increase in heart failure. And I couldn't find any stuff on microvascular disease. And then we have GLPs, they've not been studied. The meglitinides have not been studied. And then I just showed you all the tight glucose control stuff, showing that no evidence of benefit, maybe some harm associated from a mortality perspective, but I wouldn't say that. And then a 2% reduction over sort of the 3 to 5 years period of some of the microvascular endpoints. So that's the evidence that we have for treating type 2 diabetes with medications. The unfortunate thing is all of these drugs do have side effects. I'm not going to go into them, but these are the typical ones that you see, obviously. Hypoglycemia, most of them cause weight gain, but not all of them. And so the nice thing about it is we do try to use medications, at least if they don't work, at least they don't cause side effects, but unfortunately many of them do. And then there's also other side effects associated with the treatment of type 2 diabetes. There's a cost associated with it. This is the estimated annual cost to patients. This is about $150 to $600 a year for medications, and then for physicians' visits. So there is a cost associated with this sort of aggressive, or at least treatment of type 2 diabetes. So I've tried to say, here's the benefit that we know, here's the harms, here's some of the costs.
I came to the conclusion that something must be wrong.
And I think anyone who looks at this data there is something wrong with what we're doing. And I'll try and put that into perspective. It gets even worse. Routine self-monitoring of blood glucose. So, Cardiff has suggested that on average, when you look at the people who have type 2 diabetes, they are using about 10 strips a week. It's probably, hopefully getting a little bit less because we're putting out lots of good information about saying why you don't do that. And that runs about $400 a year for type 2 diabetics. There have been numerous reviews that have looked at this, one that I participated in. And here's the bottom line on type 2 diabetics who are not on insulin. Type 2 diabetics not taking insulin, routine measurement of blood glucose does not improve glucose control in a clinically meaningful way and may overall reduce quality of life. But it sounds like it should be a good thing to do. But when you look at the well-designed trials, it doesn't support it.
I still don't get it.
Okay, so let me try and put it into context for you. So, this is another really cool piece of information. This is the quality of life scale. Now, this is not definitive work, but this is some people who've attempted to look at things that affect quality of life. At the top is perfect health. You get a score of 1. And then as you do certain things, they apparently reduce quality of life. And you can see when you get down to blindness and dialysis, that's pretty bad stuff, that their quality of life drops. One thing you might not notice is something in purple. Comprehensive diabetes care reduces the quality of life roughly the equivalent of at least a mild stroke. So when we engage people in this process of treating type 2 diabetes, their quality of life drops. That is of concern because our job is not to make people feel worse. Now, this is not a perfect evaluation of everybody looking at every one of these outcomes and doing perfect quality of life, but it's interesting that there is a reduction in quality of life when you do this.
Well, what's fun about that?
There's nothing fun about it. That's the whole point, is that it's an important issue. And in the trials that I've been reporting to you, most of them have been out in the last 3 or 4 years. There's been some really great trials in the last 2 years that have come out. And these are published in major medical journals, and they're looking at the exact questions that we really want to ask for in type 2 diabetes. This is a trial that just came out in Lancet 2012, where they looked at screening for type 2 diabetes. It sounds like it's a good idea, but unfortunately, they screened 15,000 people, followed them for 10 years, and screening for type 2 diabetes was not associated with a reduction in any endpoints that they could find. What about early treatment of type 2 diabetes? Well, this was again just published in the last couple of years. This is the effect of early intensive multifactorial therapy on 5-year cardiovascular outcomes in individuals with type 2 diabetes. And it was 3,000 people, mean age 60, which is a typical age for a type 2 diabetic, and they did what everybody is supposed to do. It's called the steno evaluation. They did lifestyle and metformin, blood pressure statins, and they found that it was associated with a small, non-significant reduction in the incidence of cardiovascular events and death. So if it was non-statistically significant, we typically say it wasn't. Now, the nice thing about it, at least it wasn't harmful. So that's good.
With all due respect, this is preposterous. It doesn't make any sense.
Exactly why I'm presenting it. Because what I'm trying to do is, as best I can, to give you the best available evidence that I could find on the treatment of type 2 diabetes. So as pharmacists, we often promote how good we do things. And this is an advert from the 60th anniversary of the American Pharmacists Association. And they said, look how good we are influencing health outcomes. Our pharmacists can get patients, we can lower their A1C, we get their LDL levels to go down, and we can decrease blood pressure. And that sounds like a good thing. When you go look at the study that supports that, let me show you some of the data. If the patients that they were treating had these really big numbers of glucose, really big numbers of blood pressure, there is outstanding evidence of benefit for the treatment of those patients. The outcomes are reduced in ways that almost everybody would take therapy, as long as it didn't cause side effects. The problem is, in these trials, this is what they did. They took patients and they took their A1C average from 7.5 down to 7.1. That was what they were able to achieve. Their LDL went down by 4%, and their blood pressure went from 133 down to 130. To do that, they had to increase drug costs 50%, because it is the only way, really, that you can get a big impact on these surrogate endpoints. What's the problem with that? Well, I just showed you that decreasing A1C shows no benefit in well-designed randomized controlled trials and maybe even some harm. And in fact, not all the guidelines, but some of the guidelines, especially in the elderly, are being revised to say A1Cs of 8 or 9, especially if you're elderly, is quite good. You almost want to go, well done. You're alive and eating. You did a good job. We know that there are no studies that looked at decreasing LDL, and only statins reduce cardiovascular disease. And the most recent cholesterol guidelines that came out have basically said nothing works other than statins. And I haven't shown you this data, but the decreasing systolic blood pressure, the most recent guidelines that just came out in the last couple of weeks have backed off a little bit on the aggressiveness of blood pressure numbers because we just didn't have the evidence. And there's a whole story about what I can tell you about the guidelines, the Canadian guidelines, and how they make decisions, but that's another story. So we have a lot of diabetes educators, and they do some wonderful things. Don't get me wrong. They're good. They can help people make sense of some of these things. But if they are very target-driven, which a lot of these diabetes educators are, I think it's of no benefit. And I think it's potentially harmful, unless you're really motivating people to do some things that have some benefit, and I'll show those in a minute. And so, given that, maybe Tom Hanks would say this.
Stop it! Stop it, you zealots!
Because we become so focused on getting these people to these numbers, we lose track of things. Just recently, last year, there was the Look Ahead trial where they took the cardiovascular effects of intensive lifestyle intervention in type 2 diabetes. They took 5,200 overweight type 2 diabetics, intensive lifestyle intervention of calories and activity, and the study had to be stopped early because it showed no benefit. And they did it for 10 years. At least it didn't show harm, but they had to stop it because there was no way they were going to show any benefit. There is some positive news. This was just published in the last 3 or 4 weeks, an evaluation that looked at people who are being physically active. It's really hard to do randomized controlled trials, but there's at least some suggestion that being physically active can maybe lower risk of cardiovascular events. But realizing this is not a randomized controlled trial, but it was published in The Lancet, and it was an attempt to take people who have impaired glucose tolerance and see if it makes any difference if you walk more or less. But it wasn't a randomized controlled trial. It was a cohort analysis. One of the things that Tom Hanks was told was this.
A major risk factor for type 2 diabetes is gaining weight and then losing weight. And most people do it by accident as they try to go on diets. Tom Hanks did it on purpose a couple times.
So if you listen to what was being told about the story, they said, well, the reason Tom Hanks has type 2 diabetes is because he gained weight for roles and then he lost weight and then he gained weight. And it's called cycling. The problem is if you go look for the evidence, it's not true. I could find 3 evaluations for this, and all of them said there is no association with weight cycling that shows that you get more type 2 diabetes if you have weight cycling. But it's fascinating how people can report things as if they're true, but when you look for the evidence, it just doesn't support it. So weight is actually an important issue. Tom Hanks' BMI was about there when he did Castaway. He lost a lot of weight. When he did A League of Their Own, he was heavier. His BMI would have been around just over 30, which would be considered obese. And I think right now that's probably where he is based on what I can get from him. That's where his BMI is right now, about 26 or 27. That is considered overweight. A League of Their Own, he was obese, and when he was in Castaway, he was normal. But what does weight have to do with outcome? There have been numerous evaluations of this. This is one of the more recent ones. This is a graph of if you're higher up on these curves, the worse the outcome. This is an evaluation that looked at BMI and to see what happened to mortality, cardiovascular disease, and cancer. And you can have a look at this. What's the best BMI that you could have for cardiovascular disease, cancer, and mortality? I don't know if you can see the numbers. About like 26 or 27. And that's considered overweight. But that's the lowest risk for cardiovascular disease, cancer, and mortality. And there's other data that support it really, really clearly. And there's been other studies that have just recently come out. There's a couple that have just come out in the last couple of years that suggest maybe a BMI of 24 is the best one. But what you can notice with all of these BMIs is there's almost no difference whether you have a BMI of 22 or 27. You only once you start to become really quite obese do you develop an increased risk of cardiovascular outcomes. So if you're really thin or really fat, that's a problem. But if you're in between like all us normal people, there's really no difference in weight. Now, if you don't like how you feel with a certain weight, that's a different story. But if you're doing it for health reasons, at least for cardiovascular and cancer and death, there doesn't seem to be any difference. So that's what he looked like then. That's where he would fit on that graph. This is what he would do when he was what they would call obese. And he's right there. He's perfect. It's a perfect weight for him if you're looking at outcome of cardiovascular disease. So he said this.
My doctor said, look, if you can weigh as much as you weighed in high school, you will essentially be completely healthy, will not have type 2 diabetes.
Right.
And then I said to her, well, I'm going to have type 2 diabetes because there is no way I can weigh as much as I did in high school.
What did you weigh in high school?
I weighed 96 pounds in high school.
But we become obsessed with weight when, in fact, the best evidence is, and if you're ever wondering, what does a perfect physical specimen look like? You cannot find a healthier looking person, not looking maybe, but BMI person than me. I've nailed my weight perfectly. I'm at 26.5 BMI. So, I'm going to give you the Forrest Gump approach to some things that we should be doing.
For some reason, when I was doing, it seemed to make sense to people.
I'm trying to give you some common sense. So what should we be doing? We should be encouraging people to be active and eat food that they enjoy and not make big pigs of themselves, but useful nutrition. I'll say what that means. Should we measure glucose, blood pressure, and cholesterol? Maybe. But we shouldn't give people diagnoses of diabetes, high blood pressure, or high cholesterol. That's not what we should be doing. What we should be doing is saying, what that means is your risk of this is this. And we have reasonably good tools. They're not perfect, but we can do that. So that's what we should be doing. And then we could inform Tom Hanks about that. And then we could say, these are the treatments that we typically have. And we will not tell them they work by lowering glucose, blood pressure, and cholesterol, because we don't know if they do. But we'd say, this is the evidence that we have for that they reduce outcomes of heart attacks and strokes and so on. And then we let them know all about the side effects, the cost, the surrogate measure, and convenience, and then let him make a decision about whether or not he wanted to be treated. And whatever decision he makes, we'd support that, because it's his decision, because he's informed.
So did I tell you? Huh? Nothing to worry about.
This is just a big foul up.
And I think we've fouled this thing up from a concept of type 2 diabetes. And it's not, again, people with the very, very high glucoses, there are clear health issues, but when the vast majority of patients are in that lower range, I think we don't have great evidence for that. So let me give you the bottom line. So decoding a type 2 diabetes message, and this is based on the best available evidence that I could find. Really big glucose numbers cause symptoms and likely an important increased risk of cardiovascular disease, but 90% of people don't have those big numbers. In a 57-year-old male, a new diagnosis like Tom Hanks, if they had an A1C of 8, I don't know what his number was, but let's say it was 8, means instead of saying you have diabetes, what it means is you have, compared to if you didn't have that number, you'd have a 4% increase in the 10-year risk of developing cardiovascular disease compared to a non-diabetic or a normal person. And you have a 0.5% increase in your lifetime risk of dialysis and blindness. All important endpoints. And if there was something we could do to get rid of those risks, we would absolutely do it, as long as it wasn't harmful or be a real drag and costly. Morbidly obese patients, there's no doubt, should eat healthier and probably less overall. There's no doubt, and I'm sure you've seen, the very morbidly obese, they have all sorts of health outcomes, and it's not just cardiovascular, it's joint problems, they just can't, they're physically inactive, they have more increased risk of depression and so on. So morbidly obese people absolutely should eat healthy and less overall. The best evidence that we have for diet, and it's not very great, but the best evidence that we have is the Mediterranean diet. But interestingly, the best evidence for reducing cardiovascular disease comes from evidence from the Mediterranean diet. It almost has no effect on blood pressure, cholesterol, or weight. That's fascinating to me. We should be encouraging regular physical activity, and it doesn't matter whether it reduces any of these surrogate endpoints, because even if it doesn't reduce cardiovascular disease, I think it does based on the best available evidence, but it's not perfect evidence. But there are good randomized controlled trials showing reduction in improvements in quality of life in general, not always, but in some, and it improves a number of other aspects of less depression and so on. I showed you the evidence of screening for diabetes. A well-designed clinical trial showed no effect on important outcomes. Early treatment doesn't seem to do much. The diagnosis thresholds are all relatively arbitrary. Remember, the measurement of glucose is plus or minus 5 to 10%, not 5 to 10% on A1C, but on that measurement. And so if you're going to make a diagnosis of A1C, of the diabetes on the measurement of A1C, you probably need to repeat it because it may go up and down based on for a variety of reasons. We have many drugs that lower blood glucose. but lowering glucose often doesn't lead to a clinically important benefit. Metformin has the best evidence for reducing cardiovascular outcomes, and that's why we use it. But I showed you that there's a meta-analysis, so when you put all the best evidence together, it doesn't show a benefit. So this is even trickier. The nice thing about metformin is it doesn't cause hypoglycemia. It's relatively inexpensive, but it does have side effects. I've already shown that measuring glucose in people who aren't on insulin doesn't do much except increase worry and cost. The best BMI for mortality in cardiovascular disease is basically anywhere between 22 and 28. I think I've shown you that weight cycling doesn't seem to be linked to the development of type 2 diabetes, even though people will tell you that it is. I haven't shown you this data, but if you had to do anything if you were a type 2 diabetic, if you had important blood pressure numbers, the evidence is not relative, it's quite clear that you get greater benefit if you lower blood pressure in a type 2 diabetic or you give them a statin. You get much more benefit. You don't get a huge benefit, but it's better than if you lower glucose. So when we're talking to a type 2 diabetic, glucose is now becoming not nearly as important. What we're focusing on is control of blood pressure. And I think it's really important that we should be getting people not to think about, oh no, I have diabetes. Because you could see the way it was reported in the news media. It was like Tom Hanks had just said, I've got minutes to live. And that's not, and maybe that's, I don't think he believes that, because I doubt his physician said it that way, but the way the media presents these things is very confusing. So you should be thinking about overall risk. And for the vast majority of people who have type 2 diabetes, it's a surrogate disease. It's just, you have a risk factor. But it doesn't come across that way when we talk about type 2 diabetes. There are some changes that are occurring in the diabetes guideline, in some 2012 guidelines. The American Diabetes Association, and these guys actually did a fairly good job. And they are now starting to say, you know what, the desires and values of the patient should also be considered. Of course it should, but at least they're saying it explicitly. And they said that utilizing, and one of the things that many healthcare environments are now providing either positive feedback or even money for getting patients to certain targets. And this is a huge problem in the States because we've got people with the best of intentions targeting people to certain A1Cs, but we have evidence that it doesn't do anything to outcome. And so there's been a big shift. And it's hard to shift things. When people get paid to do things, they do it. And they're saying that we should be stopping these sort of quality indicators. That those are the wrong quality indicators that we're using. Some people, whenever I give these sort of talks, say, well, yeah, but I'll get sued if I don't follow the guidelines. Well, there was something of value in the Canadian diabetes guidelines. I mean, there's some good stuff, don't get me wrong. But they said this. As per the CMA Handbook on Clinical Practice Guidelines, they should not be used as legal resource in malpractice cases. They had to explicitly state it because everybody who gets nervous about guidelines worries about it. So, sort of the bottom line is, when it comes to activity and nutrition, what can we do for someone? If it was Tom Hanks and I was having an evidence-based discussion with him, some of the best evidence that we have of getting people to be more active is wearing a pedometer. We're incredibly goal-oriented people. We want to get to that number. And so the suggestion is that if you can get to 10,000 steps a day, that's good. Does it have to be 10,000? No, it's an arbitrary threshold. But we want you to be more physically active. Just like if you really want vitamins to be effective, here's what you do. Buy vitamins, find a friend who lives 5 kilometers away, take the vitamins to their house every morning, wake up, walk to their house, take the vitamin, which does nothing, and then walk home. That way, vitamins will work. I've mentioned the Mediterranean diet. You know what's wonderful about the Mediterranean diet? It's absolutely delicious. There is so many good things in there. And it has the most important beverage, wine. So we'd be recommending, that's what you should be doing. Don't focus so much on your weight. We'll talk about the risk of heart attacks and strokes and so on. Talk about the treatments. Can we reduce risk or not? Talk about the side effects. And again, it's very similar to what I just talked about. And it's about a shared decision making. It would we would not be going, oh, Mr. Hanks, you've got type 2 diabetes. If you could just become the same weight that you were when you were a teenager, it would go away. It's probably true, because if you do lose weight, your glucose does come down. But we don't know if it improves outcomes. So after hearing all this, you might say this.
Oh, this is the coolest thing I've ever seen.
Because what I'd like to do is have anyone, him included, to understand what the benefits and harms and the evidence that we have for type 2 diabetes. And maybe after hearing all that, he would say this.
Lesson learned.
And then this.
That's all I have to say about that.
And I'll just leave you with this one last little bit, which is this.
To infinity and beyond! Buzz,
We need to ask you a few questions.
So I'd be happy to answer any questions, and I hope you enjoyed it, and I hope you learned something. So thanks for listening.